Okay, I'd like to call the next session in. So, good afternoon again. It's with great pleasure to introduce our keynote speaker today, Sir Brian Greenwood from the London School of Hygiene and Tropical Medicine. He's the Manson Professor of Clinical and Tropical Medicine. And I just wanted to give a little bit of background about Brian. I think most of you in this room know or have heard of him through his numerous publications. I think he has more than 600 to his name, so we all have something to live up to there. But Brian started off as a clinician in a Hammersmith hospital in London after doing his medical degree there, and then got the chance to go out to Nigeria, where he was helped setting up a hospital there, and that was during the time of the Biafran War. So quite a difficult, challenging time there. During that time, he developed an interest for research and was successful in gaining a Wellcome Trust fellowship to be able to further his studies in clinical immunology. And then returned to Nigeria after that and was instrumental in setting up a medical school. And from there, he developed the latex agglutination test for meningitis, which is still used today. So he's not only a prominent malariologist, but also has expertise in other diseases. He's evaluated and still is a key investigator in the evaluation of the meningococcal vaccine, also for pneumococcal diseases, and more recently for Ebola. From Nigeria, he moved to the Gambia, where he was working at the Medical Research Center there. And during his 15 years that he was based in the Gambia, the center grew by fourfold, with a lot of the key researchers being African scientists. So he has a real passion on investing in capacity development, particularly in Africa, where he spent most of his working life. And from then on, in 2008, he was awarded the Hideo Noguchi Prize for outstanding contributions to research. And with the money that he won from that, he actually contributed that to developing a scholarship fund for students to study masters both in London and also in Japan. And so far, 30 students have benefited from that. In January 2012, he was recognized by the Queen and knighted, and so became Sir Brian Greenwood for his contributions to malaria research. And then more recently, at the end of 2015, he was also awarded a prize by the Medical Research Council in the UK, again for outstanding contributions to scientific research. So with those few words, it's my great honor to introduce him and bring him to the stage. Thank you.
Thank you very much, Jenny. That's tough build up to live up to, so I'll do my best. So thank you, everybody. Thank you to Peter and to the Dean for asking me to give this talk. And thanks also to Peter and to Mala for involving me in the ISOMER project, because I've had the privilege during the last 6 or 7 years to be the chair of the advisory committee for the South African and the Malawi isomers, and it's been very rewarding to see how those have developed and expanded during that period. So what I'm going to talk about is the use of drugs to prevent malaria in children in endemic areas. So I'm not talking about tourists, people going for short-term things. This is how can we use drugs for preventing malaria in children. And I sort of got into this. This is a party, a children's party. These are my children, so a couple of my children there, not all my children, a few of them are there. And they were brought up in West Africa, as Jenny said, in Nigeria and in the Gambia, in very highly malarious areas. They never had malaria. And why did they not have malaria? They did not have malaria because we were quite careful about their prophylaxis. Initially, it was easier. You could use proguanil, which is a very safe drug. But then we had to move to proguanil and chloroquine. And so it really made me start thinking, well, if that was the case, why didn't we use this intervention for African children? Is this something just for expatriates? So that's how I sort of got into this area, and this is what I'm going to talk about. So I'm going to talk a little bit about the history of the use of drugs in to prevent malaria in endemic areas. And our problem is, if you ask people of my age to talk about malaria, it's not long before they start talking a little bit about the history. And I think that is important because malaria goes through its cycles, and there's still much that was done 100 years ago that we're still talking about now. And it's really important that we don't forget some of those messages and make the same mistakes. And then I'll go on to talk a little bit about where we are with seasonal malaria chemoprevention and some of the approaches that are being used currently now that are actually happening to protect these children, you can see here. And then finally, a little bit about the challenges to this approach to malaria prevention. So as I would say, there's nothing new in malaria. We can go back to hundreds of years that quinine was used for preventing malaria in endemic populations. But it was expensive, and it was only the elite, certainly in Europe, who could afford to use quinine when they went on to at-risk areas. But in the end of the 19th century, Indian government actually increased the production of quinine in India, and it was distributed at a subsidized price to quite large groups of the population. I think that was mainly to people who were working and were making money for the Raj, but some of that, I'm sure, went to children. But nothing really much happened for the next 50 years because this was an expensive drug. But Dr. Koch, who many of you will know as the person who discovered tubercle bacillus, he had a rather disastrous clinical trial, which resulted in some of his patients dying, and he rather had to leave Germany, and he became a malariologist. And he went first to Uganda and then to Papua New Guinea, and he realized some of the things we're going to talk about later, about immunity to malaria, the possibilities of damaging that if you gave drugs, but he did recommend this as an approach, and at that time he only had quinine to use for preventing malaria. And sometimes if you look in the old history, you'll hear about the Koch method. So what I'm talking about is not new. These are ideas that have been going up and down for the last 100 years. But with the advent of the synthetic antimalarials after the Second World War, which were much cheaper, then people began to get more interested in this idea of could you use these drugs in endemic populations on a relatively large scale. And my predecessor in the Gambia, Sir Ian McGregor, he did this study, whatever we are now, sort of 50, 60 years ago, in which he gave chloroquine every week to the children in this health center. Some of you will recognize that. The MRC is still working in that health center outside the capital. And he showed what you can see there, that the children did well. There was less malaria, but importantly, they gained weight, they were less anemic, and so their general health was improved by stopping them getting malaria. And when I first went to Nigeria, in the 1960s, there was what was called Sunday medicine. You saw that advertised quite widely on billboards in Lagos and so on and things. I don't know how many people were taking it, but it wasn't directed at the expatriates or the visitors. It was directed at the local population. And so at least some people then were giving daraprim as a prophylactic to their children in an endemic area. And in Senegal, there was this program called chloroquinisation in the schools when they were actually giving chloroquine in the rainy season to slightly older school children, which we'll come back to again. So not a new idea. But after about 1960s, this just sort of disappeared from the textbooks, the WHO policy, and so on, and people rather forgot about it. And why was that? Well, I think we can go through some of the reasons. Difficult to achieve. It's not easy if especially if you're in the rural communities, to get your drugs out to the people who need it. These drugs are relatively cheap, but if you're giving it to hundreds of thousands of people, there was a substantial cost involved in that. And then worry about drug resistance, a very legitimate worry. And I wonder, actually, sometimes, though I have to be careful how I say this, whether there was not in some ways, almost a racist element about that the expatriates wanted to keep these drugs for themselves, and were not so keen on seeing them spread out widely in the community, perhaps in a rather disorganized way, which would undoubtedly have increased the resistance. So there was quite a lot of resistance among people, including Sir Ian McGregor, after he'd done that study, to the use of this drug in the local population. So that was one of the concerns. Another one, a very real one, was the idea that if you did this for a while and then stopped, you'd stop the children getting their immunity, and that they would then be at more risk. So pretty well everything sort of stopped for a while then, but not completely. And this is another, you can't see this very well clearly, this is a village in northern Nigeria, in Gamzago, where a doctor called Alan Williamson was doing his PhD there, and he was really trying to repeat McGregor's study in northern Nigeria. And unfortunately, Alan got hepatitis, and he died from that, and that was a big risk that people have often forgotten. We were taking, and I noticed that this morning, somebody taking blood without wearing gloves. We didn't know the risk of hepatitis B. I had hepatitis B, nearly all my colleagues did, particularly from taking blood pricks from children, because about 5 or 10% were antigen positive. And when Alan died, my wife took over his project, and she did that for her MD, and this was the results of that study, which really was confirming what Sir Ian McGregor had shown. Perhaps one of the interesting things was, if I can use the mouse, find the mouse, was actually that the children who didn't have malaria had a better response to vaccines, and particularly to the polysaccharide vaccines. And we now know, of course, that malaria is very immunosuppressive in the acute stage. So that was an interesting study. It really confirmed what Sir Ian had shown. So when I then went, as Jenny had said, after 10 years in northern Nigeria to the Gambia, and the MRC allowed us to set up a new field station at that, we wanted to repeat that study on a larger scale, which would enable us to look at more uncommon outcomes like death and severe malaria. And this study was then done in Farafenni. It was a village randomized study, and the antimalarials were given during the rainy season. We used this drug, Malaprim, which is pyrimethamine plus dapsone, which gives you 2 or 3 weeks protection, and it was distributed by village health workers, and the volunteers in the community gave the drugs. And you can see the results were really pretty remarkable. I mean, you got a 20 and then a 40 or 50% reduction in overall child mortality. And somebody was mentioning this morning about abolishing the seasonal peak of malaria. That's what that thing that was down was doing that. That's what it did. And that persisted for 3 or 4 years. And the reductions in other parameters of malaria, you can see, were very substantial. Now, when we were planning this study, my predecessor, Sir Ian McGregor, didn't like that. WHO sent some people to the Gambia to try to stop this study taking place. Unfortunately, the Director of Health Services stood up to them and said that was not shown. But that shows that the sort of resistance there was in the accepted community, that using drugs for prevention in an endemic community was very, very strong, based on those reasons that I've said before. But fortunately, we went ahead with the study, and that was what was found. And then, very surprisingly, I was looking through the literature for something else the other day and found this paper. And this is by a group of social scientists who had managed to get the data set from this trial. I don't know quite how it had got to them, and did a very complex analysis. I can't really understand all the analysis, but the basic message from that was that when these children were followed up, the ones who'd had chemoprophylaxis stayed longer in school. And I think these bottom lines here are the ones who stayed in the secondary school. The effect was most marked in those children than the ones who went to the Quranic school, which are the ones up here. So that really was, I mean, it was a pretty remarkable finding. I mean, not only were we having an effect on the health of the children during the period in which they were getting the chemoprophylaxis, there was a long-lasting impact, and hopefully those kids have all gone to get good jobs and so on in the future. But nothing happened once again. These studies were published. They were published in The Lancet, very unpopular. I got nasty letters saying you shouldn't have been doing this sort of study. It's wrong. And the other thing that had happened about the same time was that bed nets were discovered, not discovered, but discovered as a tool that could be used for on a public health scale, and particularly insecticide-treated bed nets. And very reasonably, they're easier to use. You give them once, you get 3 years protection. They have a social benefit rather than swallowing nasty-tasting drugs and so on and things. So the whole idea, again, largely disappeared of the idea of using drugs for prevention. And people began to think, well, what, again, we go up and down in the cycles, thought, well, what was the real problem with what had been happening before? One of the ideas was the thing that resonated perhaps most with the scientific community was that you impaired immunity, and that was a bad thing to do. You protect the children, and they'd all die of cerebral malaria when they were teenagers or when you'd stop that intervention. And so the idea came of what became known as intermittent preventive treatment, and that sort of took over a little bit from the idea of chemoprophylaxis. And perhaps we should just have the definitions there. So with chemoprophylaxis, like you would give for a tourist or somebody going for a relatively short period, you want to keep the blood levels up to the protective level all the time so that there's no chance that the infection will break through. The idea of intermittent preventive treatment was that there would be gaps. You'd have a period of protection, then you'd let people get malaria for a bit, and then another period of protection. I've always thought that was a bit odd, but I mean, if you want to stop people, then do that. But that was the idea behind it. And as many of you will know, that this was first developed in pregnancy, in a classical study in Malawi, when I think there probably was some when there probably was some chloroquine resistance happening, so chloroquine didn't work very well here, but giving sulfadoxine pyrimethamine just twice during the pregnancy protected these women. And that became, following another study in Kenya, became recommended WHO policy and has been highly successful in intermittent preventive treatment in pregnancy with SP. But very interestingly, just recently, WHO has recommended that SP should be given every month, not just twice during the pregnancy. And of course, that's really come back to chemoprophylaxis again. So we have this sort of dichotomy. Now, I'm not going to talk about malaria in pregnancy and IPTP. That's a big subject and would require a separate lecture. But it was important to bring that in because that's how the idea of intermittent preventative treatment arose. So people then began to think, well, if this works in pregnancy, are there other groups that we could use this approach, intermittent preventive treatment? And who are the other groups that are most at risk from malaria? Well, you can see here it's the infants, children under 5, school children, and then perhaps people with some particular conditions. And the top one was the first to be investigated, the intermittent preventive treatment in infants called IPTI, you'll see in some of the notes. And my colleague at the London School, David Schellenberg, who was then working at Ifakara in Tanzania, had this idea, well, we use IPTP and why it's very easy to give and cheap and cost effective because the woman has already come to the antenatal clinic. All you have to do is just give her the drug. You don't have to go and find her. So what is another group who are coming to the clinic? Those are the children who are coming for vaccination. So why not just give them some antimalarials at the time they come for vaccination? And this is what he did in this defining study. And you can show that over the first year of life, the children who had SP had less clinical malaria. The results were highly significant. So based on that, led the group of people, and they've always, in spite of all the antagonism things, there's always been a few people who sort of were quite keen on this idea. And they came together and set up this IPTI consortium to try to take this forward, and this was funded by the Bill and Melinda Gates Foundation. And a series of studies were done. You can see here in different countries across with different levels of malaria endemicity. And the basic message was that in the first year of life, you got about 30% protection against clinical attacks of malaria. And this is pretty consistent. You can see the 95%, with one exception, the 95% confidence limits are all above naught. And even the impact of IPTI. So that really is just summarizing some of the things. It was very easy to give. It was safe, highly cost effective because the children were there. And in the initial studies, there was no effect on drug resistance. So it seemed a pretty good idea. And a bit later on, there was a study done in, why is that not? Got stuck. There we are. A study done in Mali by Al-Sadiqo and his colleagues, which even showed that it had an impact on mortality. That was a sort of phase 4 post-intervention type study, perhaps not quite as rigid as some, but it certainly suggested that IPTI was a very useful intervention. So what's happened? Not a single country has introduced IPTI. Sierra Leone is talking about it. I'm not sure whether they're actually going to do it. And so I think it's really interesting to know, why did that not happen? And this paper here, if people are interested in the social science of some of these things, you can see the paper there at the bottom that goes into some of that. And those are the possible reasons they were able to identify. And a really important one was that IPTI was seen as coming from the outside. It didn't have a very strong African leadership involved right from the beginning of the program. The effect was relatively modest. It was only 30%. And really importantly, I think, was the changing age pattern of malaria that we've heard about. So if you look in a very high transmission area, really the highest of what it was like in many places 20, 30, 40 years ago, the peak of really severe malaria and the deaths for malaria were in the under ones. So that made sense for IPTI, because IPTI would actually just give you protection for that period. But as the incidence of malaria transmission goes down, the peak moves. And sort of about the time IPTI was being considered, many countries, the peak age of severe malaria was moving away from the very young infants into the older children. And IPTI was not going to work really very well there. So the obvious thing, well, should we move the age a bit further and actually start giving drugs to older children rather than just in infancy? And that was the idea of what was then called IPTC in children, moving from the infants to the older children. And when this has been thought about, we thought, well, actually, maybe if we could do this in areas where transmission happens during just a short period of the year, that would be the right place to start, because you wouldn't have to give so much drug, that would be cheaper, it would be more cost effective than if you're having to give that throughout the whole year. And I think we've seen slides already today from Dan and from others that in much of the Sahel and the sub-Sahel, and about a third of the population, or perhaps even approaching a half of the population of sub-Saharan Africa, lives in those areas. Malaria is restricted to a very short period of the year. So that seemed to make the sense to start there, that we would give the drugs just during the period of peak malaria transmission. And the first person to do this was a PhD student, Badara Cisse from Senegal, who did this as his PhD thesis. And so we have some PhD students here. You should take encouragement that your PhD thesis can lead to a WH policy recommendation in the future. Not many people achieve that, but it's possible. And that's true. That's what happened, as I'll tell you. So he gave a SP plus artesunate 3 times during the rainy season. You can see first, second, and third dose. And it had a dramatic effect, not surprisingly, on the impact of malaria with an 86 or something % protection. So as with IPTI, that again, a group of people who were interested in this came together, and we had a meeting in Dakar in Senegal in 2008 to discuss these results. And a lesson learned from IPTI, which was absolutely critical, that the senior African scientists were involved in this right from the beginning, and WHO and the people from that. And it wasn't seen as some idea coming from the outside. And they made major contributions throughout the whole process of what we now call seasonal developing and implementing seasonal malaria chemoprevention. So then, as with IPTI, the group came together, did a series of studies. You can see there again the different countries in the Sahel, nearly all of them, I mean, really dramatic effects with really quite high levels of efficacy. And I think the total there was 71% against clinical attacks of malaria. And in some of the studies, they gave the drug once every 2 months, others once a month, and that was pretty clear. You can see from that. If you gave it once every 2 months, you didn't get such a big effect. And that's not surprising, because these different drugs were used, but they nearly all used, I think they all used sulfadoxine pyrimethamine, which persists and give you protected levels for about a month. So you wouldn't expect to get such good effect if you only gave it once every 2 months. So that really was the the message from that. You have to give seasonal malaria chemoprophylaxis once a month during the period of peak malaria transmission. So one of my colleagues Matt Cairns, looked into see, well, where would this be a suitable thing to do? Where is the seasonality of malaria most marked? And it was surprising when he did a sort of global literature search. There were actually only about 20 or 30 studies that actually looked at the week by week. This is pre-isomer. I think there'll be some more data now post-isomer, but pre-isomer, there were very few longitudinal studies that had looked at the risk of malaria by week. And he then looked at those studies, looked at the climate at that time, and in particular the rainfall, and said, well, can we use the rainfall you have as a proxy of where it might be useful to use SMC? And not surprisingly, the area of sub-Sahel here, that right the way across to sort of Chad and Sudan. But what was surprising was people hadn't realized, and is relevant to the South African isomer, which we've discussed several times, is that there is an area there in southern Africa where malaria is also very seasonal, where the pattern looks rather similar to what you'd see in the Sahel. And I think Bill showed a slide of that from the Mozambique border. But that was not considered by WHO when they came to consider this as suitable for that, because there was no drug that could be used. And what can be used in the Sahel countries, sulfadoxine, pyrimethamine, plus amidaquine, probably wouldn't work in southern Africa. So when WHO made this recommendation in 2012, it was restricted to countries in the Sahel and the sub-Sahel. And that's what it says. So this is now an official policy recommendation coming from a PhD student's project. And this is the potential of this, assuming that you had 70% coverage and 70% efficacy. In fact, the coverage is proving higher than that. Many countries are getting much higher than that. This is the sort of number of cases you could present. So potentially, this intervention could present for something like 50,000 deaths a year. And I don't know what would happen if it was implemented with another drug in southern Africa. Probably not a huge addition, because the attack rate is relatively compared with the Sahel less, but there is a potential for more savings. So what has happened gratifyingly is that when WHO made this recommendation, UNITAID came along and raised the money to implement this on a reasonable scale. I think they made a grant of sort of 30 or 40 million euros to pilot this, if this control intervention could be delivered through routine health services. And the grant went to the Malaria Consortium, and working together with Save the Children, with MSF, Catholic Relief Service is the other group that they're working with. They've been distributing it across the country. You can see getting up to really quite substantial levels. And I think this year they're hoping that 10 million children will receive this intervention. So it has challenges. I'll come on to those at the end of my talk, but it's a nice story going logically from a PhD through bigger trials, scientists coming together, WHO recommendation, and a implementation, all of which has happened in sort of a relatively short period of time. Now, we heard several times today about school children, and I think there's an increasing recognition that as malaria transmission goes down, malaria in the school children becomes more important. And we go back to the curves again. As your transmission goes down, not surprisingly, the age distribution flattens out. So there has again been an interest again in the idea of, well, can we expand the age of SMC is recommended just up to 5 years. Can we expand that to older children? And in fact, Senegal has taken the decision to go against WHO's recommendations, and they give SMC in children up to 10 years of age, because they've seen that that's happened. But this has revived interest in the idea of doing something specifically focused at school-aged children. And as I've said before, there's nothing new in malaria. There we go back to 1955. There was the idea of giving school children anti-malarials regularly, and it was found that they reduced the absenteeism from school. But probably an important study that really sort of raised this idea was this trial here done in Kenya by Sean Clark, which again showed that really the important thing was that when they gave SP plus amidiaquine once a term in the school, it had an effect on anemia, and that probably was the reason why the children did better at school. And then there have been several more studies. I've just picked one here from, again from Uganda, when they tried giving the anti-malaria once a month or just once during the school term. And you can see at the bottom line there, giving DHA piperacin, which was used in this thing, almost abolished malaria from those school children. Once a term was probably not enough. So I think it's an interesting area, and as we've had, much more interest in learning as to what we can do about preventing malaria in school children, how this might be used. And these are the problems: what drug would you use, side effects and compliance. And unfortunately for the Sahel countries, the school holidays coincide with the period of maximum malaria transmission. So that's a problem that might not be the case in Southern Africa. So are there other groups? Well, this is sort of expanding. We started off in infants, then to older children, then to school children. Well, yes, there are, and these are some of the other groups that have been considered for this. This is called IPT-PD, IPT post-discharge from hospital. And there was a study done by CDC in Siaya Hospital up on Lake Victoria many years ago, which came out with really shocking results that the children who were discharged from hospital, who had been admitted mostly with severe anemia, mostly with malaria, the mortality rate in those children in the subsequent weeks was very, very high. And so that gave FICO and his colleagues, Turkuil and his colleagues in Malawi, somebody we have here, the idea of giving antimalarials to the children who'd been admitted to hospital with severe anemia just for a few months after they left the hospital to stop them getting malaria and worsening their anemia again. And you can see there that that really seemed to be quite effective. They got a sort of 40% reduction in children being readmitted to hospital. And that is now being expanded. I understand there's at least two, and Don's still here, he's probably involved in one of those. There are at least two more trials that are going to be undertaken. One is a multi-center trial of following this approach. And another group are the children with sickle cell disease. I mean, it's been known and for a long, long time. So I think we had somebody here from Nigeria was asking questions. They used to give proguanil for that, or perhaps pyrimethamine for many, many years after those drugs were no longer working in the sickle cell clinic. And this study was done by Abdul Razik, showing that actually using mefloquine was actually quite a good drug. Mefloquine plus artesunate was quite a good drug because it gave a very long period of protection. So there may be other specialist groups at higher risk that this approach can be used. And lastly, I just want to say a little bit about mass drug administration, because this is not aimed at particularly at children. This is the usual definition: administration of a full therapeutic course to a whole community, usually with the aim of interrupting transmission. I mean, not as a disease control activity. And again, WHO was very anti this. They were very anti against using drugs for prevention in any way. But recently, policy has been changed, and there's a WHO recommendation from the MPAC committee last year, which said, well, it's appropriate to do this in three situations: elimination programs, epidemics, and in emergencies. And one recent emergency that, as far as malaria is concerned, I'm sure many of you are familiar with, was the Ebola outbreak, which is generally thought to have killed more people from malaria than from Ebola. And the National Malaria Control Program in Sierra Leone did a heroic study in which they gave mass drug administration to 2 million people in Freetown and roundabouts at the height of the epidemic to stop people getting malaria, including the children. And the really important thing about that is if you got fever, you went to an Ebola treatment center, you could be put in the waiting areas next door to somebody. If you had malaria, that was diagnosed next door to somebody who generally did have Ebola. So by reducing, that was the aim of that. So that was an example, I think, of using mass drug administration in an emergency. And then there are various studies going on the Thai-Burmese border with MDA being used as an elimination strategy to try to get rid of artemisinin-resistant parasites. And this is a picture of one of the studies going on which Francois Nostin is involved in. So a lot has happened. The drugs are becoming much more widely used, hopefully in a more sensible, rational way, with a science underpinning their use, rather than just what's happened in the past that are rather haphazard. So what are the challenges? I mean, there are big challenges to those, and I'll just go through some of these quickly. One is funding. Even though these drugs are relatively cheap, they have to be delivered, there is a cost to that. And expanding into new areas, trying to cover the whole of northern Nigeria with its very large population, will cost money. And the funding for malaria has stabled. It's certainly not going up, and that is a concern. It's happening now because Unit Aid has given a grant. What will happen after that? Will there be the funds to sustain that? It does require delivery. The mother has to bring the child to somebody who can give the drugs at least 4 times during the malaria season, and probably we can't afford to have people paid specifically to do that. So I think one way that is being explored, which seems to work reasonably well, is that you give that job to somebody who has other things to do during the rest of the year, and who is also responsible for treatment. So he's actually, if somebody will be cases who still get malaria, they're treated by this health worker, and they probably have other jobs to do. So it's not just a one-off thing, because otherwise that would be very expensive. And then there's the question of drug resistance. And this lists some of the drugs, the combinations that have been used. The WHO recommendation is SP plus amidaquine, which still works, fortunately, in West Africa, but we don't know how long that will happen. What would happen with this whole program stop if we got SP resistance coming from East Africa? And it's generally recommended that you should use a different drug for prevention from the one that you use for treating your cases. So do we know if we're going to get drug resistance? Well, this is a slightly complicated slide. This shows 3 studies in which seasonal malaria chemo prevention was given, or a placebo, and these are the resistance markers. Here for sulfonamides, here to pyrimethamine, and this was at the beginning of the SMC program, and this was afterwards. And you can see that there was an increase throughout the rainy season, and that's been found before, that with any drug, if children are getting treated because they're sick, there is some selection pressure on the parasites, and it's probably a little bit more in the children who are getting SMC, but not dramatically so. But what we find is that the proportion of parasites that are carrying resistance markers goes up proportionally, but because your parasite load in the children overall has gone down, the number of parasites carrying the resistance markers is actually reduced. And I don't quite know what that means, what the importance of that is. But there's certainly, at the end of an SMC program, when you reduce parasite prevalence from 50% to 5%, you will have fewer resistant parasites in those children than you would in the control group. But the proportion is higher, and we have to face that, and that will probably get more marked as longer this program continues. And then the other issue is the one of rebound, which has been discussed by several of the speakers this morning. And what I think, just to be sure everybody understands what that's meaning, what that means is that if you have your intervention here, and in green, and then you have your control here, and as time goes by, if we're talking certainly about Africa, the incidence of the infection will get lower as the children get older. But when the intervention is stopped, say we just give SMC for 5 years, then there is more malaria in the children who'd had the intervention for a period because they've lost their immunity. And people argue about this, but I can't see it's a reason for an argument. It's inevitable that that will happen. If you have a successful malaria intervention that stops people getting malaria and then they're still exposed at the end of that period, then you will get more malaria because they haven't got their immunity. So does that really happen? Well, going back to the study, the original study we did in Farafeni, this is the only study really that's actually followed children for a period of time. And what you can see here is that these were children who were 5 to 6 years, I think it was 6 to 7 years old, and they'd had chemoprophylaxis, seasonal chemoprophylaxis for 2, 3, 4, or 5 years. And you can see there's a nice sort of gradient. The more time, the number of years they've been receiving that when it was stopped, the bigger the chance was that they got an increase in malaria. But overall, if you add all this up, you saved many more episodes in those first 5 years than were increased in the 1 year after they stopped, and the next year they'd gone back to normal. So I think that's probably what is going to happen. And fortunately, when we looked at deaths, there was no increase. And I think that was interesting what Grant was saying. Dorsey was saying that after the spraying was stopped in Uganda, they had an increase in the cases, but they didn't have an increase in severe disease. So that probably is what was happening there. Okay. So what about seasonal malaria chemoprevention? Well, recent data, well, there are only a couple of studies that have actually looked at that. After 1 year, this is only after 1 year, there was a slight increase probably, but nothing much. But really the issue is what will happen is after 5 years when seasonal malaria chemoprevention is stopped. And I've done a little sort of thought experiment here, a little bit of simple modeling that what is happening here. This is the age group of people. Those are the 5 years when they're getting their SMC. And this is the incidence of malaria. And you can see this is the sort of thing you will see in the Sahel countries. It peaks probably at 2, 3, or 4 years old. And then the incidence of clinical attacks drop. So if you can save 50% during that time, you can still cope with a small increase during those 2 years when the overall incidence has gone down. So an 80% is not as bad as it would have been earlier on, and you end up with a benefit of, I think, something like 362. So but there will be a cost to that. This will happen, and it's no use trying to pretend that will not be the case. And then there is the issue of when you should stop. We don't want to go on giving drugs unnecessarily, and a time hopefully will come when other interventions will reduce the attack rate so that it becomes a non-cost-effective intervention. And this was, again, some work done by Matt Cairns, which showed that this is the incidence of clinical attacks per child per year up to 1.5 there. Here you're about 0.1 or 0.2, and this is the cost of SP based on 1.5 per year. And this is the cost per DALI, and somewhere around here of 0.1 or 0.2, it becomes highly non-cost effective. So if your attack rate is lower than that, you probably wouldn't want to use this intervention. So what next? Well, way forward. I think we need new drugs for doing this, and we need new drugs that will have a longer action. For treatment, you want a drug that's short action, quickly cleared, but if this is to be continued, then we need drugs with longer action, and there are people beginning to think about that. And there are some moves to the idea of developing a long-acting malarial, particularly if you could just give one treatment at the beginning of the malaria transmission season, that would be fantastic. And there are drugs, Johnson & Johnson have shown an interest in this. They have long-acting psychotropic drugs that they use for treating psychiatric illnesses. They have some of the technology and are working on that. If we could apply that to antimalarials and just have one shot at the beginning at one dose, then that would be a major thing. And then the other thing that has been developed is the idea of using your delivery system for SMC to give other interventions. And I think MSF are using this to give vitamin A, and we have just started a study last 2 years ago in Mali and in Burkina Faso of trying to add an antibiotic at the time that they get their antimalarial. And there are two reasons for that. One is that a study, I think came from here, from Johns Hopkins in Ethiopia, which showed that when they were using mass administration of azithromycin for trachoma elimination, there was an overall reduction in child mortality. It seemed really difficult to see how that had happened, but the data was good. It was a well done study. So we thought this was an opportunity. That really was an effect if we gave azithromycin at the time of the year, which is worse for the children when they have a lot of pneumonia and diarrhea and things as well. Would that have an effect on mortality? So this trial is done 2 years now. It's got 1 more year to go. And it's comparing just giving the antimalarials or the antimalarials plus amidiaquine. And we'll have an answer to that next year. So a better approach. Well, this is giving drugs and bringing the mothers to get the treatment and the side effects and delivering the drugs and so on. It's hard work. It's tough to do that. And I think, but it does have the potential in the medium term, as we said, to save thousands of lives. But it probably isn't the long-term solution. And what I hope will happen, but we don't know when, will be that there will be a vaccine to do that. And we're planning a study in which we might use the RTSS vaccine as a seasonal vaccine in the way in which in Europe I have my annual flu jab at the beginning of the flu season. You could imagine that you could use a seasonal malaria vaccination if you've only got a vaccine that gives you a relatively short duration of protection. Because RTSS probably only gives you a year or two's protection. We don't know about the Steve Hoffman vaccine, how long that will last. But a very effective way might be, if it only gives you a relatively short protection, is to give that at the beginning of the malaria transmission season. So I think perhaps somebody talking here in 10 years' time probably won't be talking about seasonal malaria chemoprevention. I hope they'll be talking about vaccination. But I think that for the present, this is a tool that has potential. It's not a perfect tool, but it could save many, many lives. So I think that's my last slide. I can't really, in a talk like this, it's difficult to give personal acknowledgements. So many people, so many of my African colleagues and European colleagues have been involved in these studies. But really, what is absolutely key are the thousands and thousands of mothers and children who've participated in those trials very willingly. And without them, we would not have had the results that we've got. So thank you.
Thank you, Brian. I think we've got time for a few questions. If anybody's got any?
I hope some challenges.
Hi, thank you for a great talk. So I was curious about the drug resistance markers that you alluded to. I think you had PFCRT as well as the DHPS up there. Yeah. And since other than amidiaquine, the drugs that you're pressuring with are not normally associated with CRT mutations. I was curious about that.
No, we have looked at the PFCRT as well and MDR in some of those earlier studies. There wasn't anything dramatic. For the current study that's ongoing, we are getting we're getting filter papers at the end of each season, but those haven't been analyzed yet. But they will be. Yeah.
So, Brian, when the malaria eradication programs ended in the 1970s, WHO came up with tactical variants. And one of them was tactical variant number 1, which was the use of chloroquine in controlling malaria. Essentially, it was providing chloroquine through all the health centers. Yeah. So it didn't work very well because we didn't have anything else to support chloroquine. But in the early stages, chloroquine was very effective in keeping malaria under control in Africa because the upsurge, which we're dealing with now, sort of happened parallel with chloroquine resistance.
Yes. Chloroquine was used for treatment, but if you would, before the sort of screen and before the diagnosis and treat, that every fever was getting treated with chloroquine. So, if you tested children under 5 during malaria transmission season, lots of them would have, a high proportion would have chloroquine in the urine. So they were actually getting chloroquine prophylaxis then. I mean, and that's probably was a useful intervention.
You got any more questions? I think just one thing I wanted to say is you were talking about how SMC or IPT might be useful for Southern Africa.
Yeah.
Well, actually, just recently at the beginning of this year, the National Malaria Control Program in Zambia is actually going to roll out MDA across the whole of Southern Province. This is based on some results that have come out of the MASEPA group that showed some good control there. Although how this is going to be done, how frequently and how it's going to be distributed at household or health facilities is yet to be decided.
I mean, I just hope that they've thought this through, because a lot of the problems with the MDA programs were actually people hadn't defined exactly what they were trying to do. And I mean, it makes a lot of difference. If you're trying to stop transmission, then you go at the time when the parasite is at its weakest in the dry season for Sahel. If you're using drugs to reduce morbidity, then you go when the morbidity is highest and things. And people have got confused about that. So I just hope in Zambia, I'm sure they have, it's MASEPA, they've really thought carefully what they're doing. Because that's partly what gave it such a bad reputation. Including Dr. Pinotti, who actually recommended putting antimalarials in salt to fortify salt. So that was used for a while. And you can imagine, I mean, best way of inducing resistance you could manage. Okay.
Thank you very much.